Did you know that 700,000 people die every year in Africa due to antimicrobial resistance? And this figure is expected to rise to 4.1 million by 2050. Hi, and welcome to the African Pharmaceutical Review podcast, where we bring you insights from the pharmaceutical industry in the context of Africa as a continent. Now, it's World Antimicrobial Awareness Week, and the theme for this year is Preventing Antimicrobial Resistance Together. Our guest today is what we refer to as a true antimicrobial resistance steward. She has dedicated virtually most of her career towards containment and prevention of antimicrobial resistance. Currently, as the Senior Antimicrobial Resistance Control Specialist at the East Central and Southern Africa Health Community. Previously, she was the national focal person in the Ministry of Health in matters of antimicrobial resistance and has published numerous reports on antimicrobial resistance. Other than that, she's been involved in the National Antimicrobial Stewardship Guidelines development in the region and focuses most of her time in supporting the implementation of national action plans for countries in the EXA region. Welcome to the show, Dr. Evelyn Wesangula.
Thank you very much for that kind introduction.
Welcome.
I really appreciate.
No problem. So we'll dive right straight into it. Assume, as hard as that may be, I'm a 10-year-old. How would you describe antimicrobial resistance to me, what it is, and why I should bother with it?
Okay, that's tough because breaking down technical information into easily understood language is one of the challenges that we've had in terms of handling and creating awareness and carrying out advocacy for antimicrobial resistance. But if you're a 10-year-old, I would talk to you from the point of disease. So microbes have the ability to cause diseases, which we call infections. So when you develop an infection caused by a disease-causing microorganism or a microbe, what would ideally happen is that your body can have the ability to clear that infection on itself if your immune system is good. But in the event that you have an overwhelming infection, then you will require treatment. And the treatment for infections that have been caused by microbes would require what we call an antimicrobial agent. Depending on whether that infection has been caused by a bacteria, microbes can either be bacteria, they can be fungal, or you can have parasites that can cause infections, or they could be viral. So in the event that you are treated with medicines and these medicines are effective, then the medicines are able to clear this infection from your system. But you can have the contrary happening. And what's the contrary? The microorganisms have discovered ways of evading the action of these drugs that you're using to clear them from your system. So when this happens, and these medicines have been administered in a dose that has been recommended by the doctor, or even a dose that is higher, but still these microorganisms that are causing disease cannot be cleared from your system, then we term that phenomena as antimicrobial resistance. So you have a microbe being exposed to a standard dose or even a higher dose. But because it has found clever ways of escaping your antimicrobial agent, maybe it's an antibiotic, it's a bacterial infection, it survives and continues to multiply. We then say that antimicrobial resistance is happening. And when this happens, what are the consequences? Number one, you end up with severe illness. Number two, if you're in hospital, you will take longer in terms of hospital stays, or will be prolonged. And if you're lucky, you will survive, but you would have paid a lot of money because your commonly used antibiotics or antimicrobial agents are no longer working. So what will the doctor prescribe? The doctor will prescribe another antimicrobial agent that is probably more expensive. So you have stayed in hospital longer, you have spent more money. If you're lucky, you will come out. But if you're not lucky and you have an overwhelming infection, if you cannot afford the newer, more effective antibiotics, for example, or they are just, even if you afford, but your infection is not responsive to the antibiotic that has been prescribed, then death can happen. And that's why you talked about the statistics. Every year we are losing 700,000 people, and the projection by 2050 is like 4.1 million people dying in sub-Saharan Africa. So that's like the economic impact of antimicrobial resistance in the society. So in a nutshell, that is what happens. You have microbes that cause disease that are no longer responsive to doses that are prescribed or even those that are higher. And that causes them to continue to multiply, to continue to mutate, causing more severe disease. And ultimately, nothing is possible when that happens.
Okay.
Yes.
So clearly, it is a very important topic, and it's a huge public health danger. That's something we should actually continue the conversation about. So there are very many options as a pharmacist in terms of career trajectories you could go towards. However, for you, it's clear that you're extremely passionate about antimicrobial resistance. And as I mentioned before, you've dedicated the better part of your career towards prevention and containment of the same. So why to you at a personal level is antimicrobial resistance so important that you made that conscious decision to pursue a career in it?
Yeah, like you rightly observed, and I actually probably haven't thought about it a lot. A lot of my years in service have been dedicated to infectious diseases. After my internship, my first posting was in Malindi District Hospital. Then now it's a county referral hospital. I was the first pharmacist in that county, and by default, the first pharmacist in the hospital. And I was really very much involved in the setting up of the comprehensive care clinic in Malindi for HIV at that point. And I began working very closely in TB HIV management. And I think my first encounter with non-compliance to antimicrobial agents started there, because I would see the tremendous improvement patients would have when they complied to treatment, especially those that were put on TB treatment. So I continued to grow my passion in HIV, TB management over the next 4 years. Then I moved into malaria, and I started working with the malaria program while still serving in different capacities. And I was involved during the transition of the policy in terms of treatment, when we were moving from amodiaquine and we were introducing the artemether-lumefantrine combination. I was part of the transition process, building capacity, and just trying to speak to the process of transitioning. So I could see the impact it had. One, I could see the challenges that came with transitioning policies, especially when you're talking about moving from less effective medicines to more effective medicines. And from that point, I realized I had a passion in infectious diseases. So I applied to do a master's in tropical and infectious diseases. And at that point, I think for pharmacists, it was not one of those career paths that was chosen by a lot of people. Actually, we were the first cohort of pharmacists to do the TID course offered by the University of Nairobi under the tropical and infectious diseases department unity. I remember we were 2 female pharmacists who went into that course, and nobody understood why we were chose. But I think we were both passionate about infectious diseases. And when I finished my TID training, I thought I would work in a program straight away, but I was posted to the Jaramogi Odinga Teaching and Referral Hospital, then the New Nyanza Provincial General Hospital. I didn't understand why. I felt a bit misplaced at the beginning, but when I got into pharmacy, I had to find my space. I spent a lot of my time in the lab because I had started growing my passion in microbiology. I would go into the lab and look at the tests, the culture sensitivity tests. I started realizing there was a gap, even in terms of the way the discs were used. I didn't have much knowledge, but I knew something about microbiology and the antibiotic susceptibility testing. And I would also go into pharmacy and start studying the patterns of antibiotic use in the pharmacy. That was like 2010. And when I started generating that interest, it spread beyond understanding what is happening in the lab, what's happening in pharmacy, I now started generating an interest also in infection prevention and control. So I was part of the team that was strengthening the IPC work at the hospital, as well as begin to conceptualize what an antimicrobial use program at the hospital would be. Before I could complete that work, I was moved. So I went into teaching. I started teaching at the Kenya Medical Training College, and that is where I dived into MR fully, because I got an opportunity to start coordinating what we call the Global Antimicrobial Resistance Partnership, which brought together multi-sectoral experts. So it was a multi-sectoral working group. One Health, we had colleagues from animal health and human health. And at that point, we had just published the first situation analysis for antimicrobial use and antimicrobial resistance in Kenya. That's in 2011. So once that was published, I read the report and I was so determined to do something about it. And I started looking for platforms and audiences to drive that. And I knew that without policy support, because one of the recommendations was on policy, and at the Ministry of Health at that point, we didn't have an active antimicrobial resistance program. I started looking for opportunities. And the earliest opportunities that presented themselves in terms of disseminating the findings, and that's the importance of sharing data, was the infection prevention and control program. So they had an opportunity, and I spoke at almost every IPC program, disseminated the data. And through that, we developed the IPC strategy. And one of the strategic objectives of the national IPC strategy was to establish a national AMR committee from a One Health perspective, NASIC. So when that was identified within the IPC strategy, the next natural thing was to have a desk at the Ministry of Health that had an AMR. And as they say, the rest is history. I was appointed as a focal point for AMR. I moved from KMTC and went into the Ministry of Health to now establish the National AMR program. And out of that, then grew the AMR National Action Plan, the policy, and all these accompanying strategies. And that has been the journey in a nutshell. It's been many years, but quite fulfilling.
And quite the journey. And that journey has led you to EXA, the East Central Southern Africa Health Community. What is your day-to-day job? How does it look like working at this regional level?
Yeah, working at the regional level is interesting. I love challenges, and I think I thrive when I have a challenge at hand. So the regional level is different because you're working with different countries. It's the same subject area, but different context, because every country is different. Kenya is different from Tanzania, from Uganda. We are very different from Zambia. We are very different from Malawi, for example, or even Mozambique. So you have language, you have culture, you have context, you have behavior. Even if you're still working on the same area, supporting implementation of action plans, my day-to-day work revolves around understanding context, one, providing technical support to the implementation of action plans. And when you go into a country, not every country has the same priorities. So I need to understand the priorities and help the country to tailor solutions that will meet their needs at the end of the day. So I think basically that's what my day-to-day life looks like. And apart from that, I also spend time in creating networks, resource mobilization, because I understand the depth of the problem. I also understand the lack of resources that have been allocated to AMR. So as much as possible, I try to mobilize resources, not just for Kenya, but also for the other countries that I work in. So I value partnerships and networks a lot, because that's the only way we can get this moving.
Now, speaking about African countries and in the African context, why is it extra important, if I can say that we need to focus on antimicrobial resistance? Considering, yes, it's a global threat, but us as a continent, is there a reason why we should be extra keen on it?
Yeah, there's a reason why we should be extra keen. And I go back to the statistics to share. The global projection in terms of deaths by 2050 is 10 million annually. Half of those deaths will occur in sub-Saharan Africa. And a similar number also, let me say 90% in sub-Saharan Africa, a similar number also in Asia. So we look at our system. One, we have very weak systems. If it's health systems, they are weak. If it's infrastructure, we also have weak infrastructure. And that also ties in with economic potential at country level. For example, poverty levels are also high in both Asia and sub-Saharan Africa. So for us, we have a double-edged sword. It's not just about the microbes and the inability to treat infection.
Yes.
It's about our capacity to even access these medicines when we need them. Can we afford them? It could be the medicines, one. Number two, it could be the diagnostics. Can I be able to even afford to pay for a simple culture and sensitivity test? Because a lot of the challenges we get aired is the patients cannot be able to pay for the lab diagnostics. That's why people are ending up self-medicating, thinking that it's a cheaper option. But in the long run, it actually becomes more expensive. And I want to give you a simple example. If you have a patient today who's admitted in the intensive care unit, and they have a prescription of a simple reserved category antibiotic like meropenem, what's the cost of meropenem?
Extremely expensive.
Yeah, it could cost that patient maybe about 100,000 or more. And remember, that's not the only antibiotic or the only medicine they are on. So by the time this patient gets their final bill on discharge, if their bill is 7 million Kenya shillings or 70,000 US dollars, how many Kenyans can afford to pay that kind of a hospital bill single-handedly? You will sell your piece of land, you will sell your possessions, and you will end up fundraising to be able to clear your bill. So I'm passionate about this because I know what it means for that common wananchi, as we call them here, who cannot be able to afford or access that most effective antibiotic when they need it, where care is not readily available, where our infrastructure is weak. So we need to be particularly careful how we handle our reasonably priced antibiotics, and that is why we need to keep them working for as long as possible so that we can access, we can afford, and we can get better. But if we don't change the way we handle them, then it's going to be terrible for us, because there are one simple infection that could be treated will be killing us. And when we'll be required to buy or access the more expensive medicines, we will not be able to afford this. So the sustainable development goals for sub-Saharan Africa will be unachievable. You cannot eradicate poverty if you don't have effective antibiotics. If people are struggling to access care, then sustainable development goal on eradication of poverty is out. Access for healthcare for all again becomes a dream, because if I cannot pay for my services, my healthcare services, then it's a problem. And it's not just a health issue, it's also in agriculture. If you're talking about the SDG that's tackling hunger, and I cannot sustain my food production system because there's a lot of use of antibiotics in feeds for growth promotion. So you can see it's a cycle that is not ending. And the environment also, we are talking about access to clean water. But if we have industries that are releasing or discharging effluent into our water bodies, what are we saying in terms of achieving SDGs? It becomes a dream. And for us in sub-Saharan Africa, we will be more hit because our levels of income are low. So we are not able to actually come in and meet some of these very basic needs that we are talking about. And we really need to make sure as much as possible we are using antibiotics or antimicrobial agents in an optimal way.
Okay, that's very interesting to hear. And looking at the same in terms of regional wise, I know you were involved in a workshop not so far back behind, with involving the Africa CDC, of course, EXA, and the Ministry of Health Kenya. in terms of forging a way forward, or the best way forward in terms of improving AMR surveillance and also strengthening stewardship. What are some of the activities happening continentally in the context of Africa that are geared towards improving AMR surveillance and generally strengthening the stewardship programs?
Thank you. I think that's a good question. And I think when we started this conversation, I talked about the amount of resources that have been allocated to supporting antimicrobial resistance activities. I must thank all the implementing partners that have come through to support AMR efforts in different ways. Even before countries that started working on their national action plans, we had like the World Bank come in and support laboratory infrastructure across several countries in the Eastern and Southern Africa. Without infrastructure, it's really hard to have labs that are fully functional.
Sure.
And as the countries took on the global action plan and began to develop their own national action plans at the AU level, we also had common position by heads of states in Africa on antimicrobial resistance. So that's political support. And through the AU, of course, the technical arm is the Africa CDC that has been able to support quite a lot of initiatives in building capacity for antimicrobial resistance from the lab network through partnerships with other partners like the Africa Society for Laboratory Medicine, the EXA Health Community. In West Africa, we have WAHO, and you have SADC in the south. So all this working together and mobilizing resources to build capacity at various levels, either through training or the development of guidance documents, which we realized we needed because sometimes you want to do something, but how do you do it? And harmonizing this across countries also, because our challenges are similar. So Africa CDC has played a key role in that. Then we also had EXA coming in also to support member states to implement AMR action plans and some of the surveillance systems. That has been a big push in the right direction, and also trying to harmonize the regional approaches in implementing stewardship programs. Then we've had the Fleming Fund. Almost every country, not every country, but a few countries have benefited from the Fleming Fund, which has been like one of our largest investment in AMR surveillance, building capacity for labs in so many countries. I think our Eastern African countries, Tanzania, Uganda, Ethiopia, Kenya, Zambia, Malawi, have all benefited from the Fleming Fund. Those are just a few that I'm mentioning, but there are more. And this has not just been on the like the hardware bit, where we've had equipment coming in, reagents being procured, capacity being built at a technical level, through different initiatives. So we've had the Fleming Fund, and then we have the USAID supported projects as well. We've had what we call the React Africa that has been driving champions, advocates, from a civil society perspective. So there's been quite an amount of like investment in terms of resources, not just the money, but also building technical capacity. But that is not enough, because we still have big gaps in terms of what needs to be done. Because if you go into one country and they only have like 5 surveillance sites serving the whole country, you realize the gap is still huge. And the governments have been slow in terms of allocating budgets to support antimicrobial resistance. So I think that has also slowed down the response. But when they will come in and actually augment what partners are doing, I think the countries will be able to do much more. We are definitely not where we were 5 years ago. When we met at continental meetings, our countries had nothing. We didn't have any data. We didn't have structures. We didn't have strategies. But now when we have these conversations, every country that has been part of this process has their own local data, however small it is. And I think it's beginning to make a big difference in terms of how interventions are being set and how policies are being written now. So we are seeing a big difference. 5 years later, we are speaking a different language. And today, even here, as we launch the Wow Week for Kenya, I'm sure the implementation report is going to be better than it was 5 years ago. Because a lot has happened across all the objective areas, from awareness to surveillance, to infection prevention and control, to stewardship. One area that we are still lagging behind is on the research and the research component and building a case for investment. That area has been very weak. We've not had a lot of targeted research and also building a case for investment. You know, if I want someone to put money, I need to build a case. So it's been a challenge for a lot of our country, largely because of the data that's available. Yeah.
So, based on that response, there's something that is coming out very clearly, and that is there are certain key stakeholders that have to be in place for this journey to be successful. And I'll take you back to a statement you've made, and you have mentioned One Health approach. What is One Health approach, and why is it important to use this approach when you're coming to antimicrobial resistance control and prevention?
Okay. One Health is interesting. Let me start by saying that it's a way of working. That's what we try to say, so that we simplify what has come out to be complex in terms of the terminology One Health, but it simply means different sectors coming together and working. And for us in the AMR space, One Health, when you talk One Health, we are looking at human health, we are looking at the environment, we are looking at animal health, we are looking at plant health. So all these sectors coming together, working from a shared vision to achieve a common goal, you know, that all of us have set. And I say, I've pointed out shared vision. Why shared vision? Because if I don't see myself in a problem, I will not play my part. And when you see your contribution to a problem and the solutions you can bring to the table, I think the process becomes easier. So it's important for all these stakeholders to be on board. And when we started this conversation, it was very difficult to onboard all these stakeholders at the same time. And I cannot believe that I'm part of a problem until data shows me that I'm part of a problem. So we started off, of course, very well with the human and animal health component. But even as the human and animal health components kicked off, we realized the human health is far advanced. Investments in animal health have been slower, and you cannot compare to the amount of investment that has been made in human health. And that actually also impacts on what they can be able to do. Then the environment was even slower, because the contribution of MR from the environment had not been clear for a long period. But now, even at the global level, we no longer talk about the tripartite. We talk about the quadripartite, the Food and Agriculture Organization, the World Health Organization, the Animal Organization, the World Organization for Animal Health, WOA. Then we have now UNEP, the United Nations Environmental Program, you know, is also now part of this conversation. So for us to reflect that One Health in a true sense, we need to be able to work together, have like common objectives that we are working on. And it doesn't mean that in all sentences within the action plan we'll be implementing together, but it's about each sector understanding what their role is in mitigating MR and playing that part. And I see the One Health approach as very critical, because 4 sectors can do much more than one sector can do. Even just in terms of mobilizing resources and reach in terms of coverage and scope of work, it's better when the teams work together. And that can only happen when you have very good like multi-sectoral coordination mechanisms. And a lot of countries are struggling with these coordination mechanisms. And that's why you find a lot of progress made in 1 or 2 sectors and very little or no progress made in other sectors. So the One Health concept is absolutely critical. And what we are now saying is that we need to start building this concept right from school. We don't have to wait until we are out of school for us to begin to talk about One Health. So how can this influence curriculum and how we are training or retraining those that have already gone through school, so that they understand that this should be a way of working. 70% of all emerging infectious diseases are now zoonotic in terms of origin.
What role do community pharmacy play, or do they even have a role?
I see community pharmacists as gatekeepers. You're the first point of contact with the community. So you're a gatekeeper.
Yeah.
You're either letting me in or not.
Yeah.
And I think for me, that's a critical person.
Mm.
You are like a make or break in this chain.
Mm.
Because when a patient comes to you have the power to support the optimal use of antimicrobial right where you are. So if we let our guard down at that point, when everything else begins to lose its meaning. So when you are as a community pharmacist, and you are in touch with the day-to-day lives of everyone in the society. You are there, you have the knowledge. So you're an educator, you have the right knowledge and you know it. So what's stopping us from giving the patient the right information? Number two, you understand the medicine better than anyone else. There's no one who understands medicine more than the pharmacist.
True.
So you know what would happen if I allowed my patients to walk away with half a dose of amoxicillin. You understand what that means. You understand what it means to administer one start dose for ceftriaxone at that point, or recommend it. You know, you know what it means to recommend an antibiotic for a viral infection. So being the gatekeeper, you have all the authority that is required to actually control what goes into the community. And I think there's a whole aspect of balancing your bottom line vis-a-vis what is right. But I look at it and say, yes, the bottom line might look good today, but 10 years later, that bottom line, even if it's good enough, might not get you that antibiotic you will need when you really need it. So for me, I view community pharmacists as the gatekeepers. And that is why when we developed the regional guidelines on antimicrobial stewardship for the countries, East and Southern Africa, we went beyond the hospital, and you rightly put it, that a lot of the MS programs are actually hospital-centric. But we know in Africa, the hospitals might not be our problem. Our problem is in the community. The enforcement of regulations, the readily access of antibiotics without a prescription. And that's why we included a community aspect in the MS guidelines. Even at a national level, if you read our guidelines, they're not just limited to the hospital, but we also have component for the community pharmacies. And we are asking all the technical working groups in countries, the coordination mechanisms, bring the community pharmacists on board. Because without this, our MS war is far from being won. Because really, a lot of people will seek help at that point in time, at the pharmacy as their first stop. So if you don't get it right here, then there's a problem. So I see a lot of advocacy opportunities, education opportunities, because you are the authority in that area, and also the opportunity just to do it right, and even to self-regulate, so that you are able to contribute to the objectives of the national action plans, and ultimately keep our medicine effective and reduce the burden of MR. Because when it happens, really, it doesn't choose. You know, any of us can go down with a resistant bug, and you see, we say our actions today will determine how our future will look like tomorrow.
100%. And still zeroing on that community pharmacy, it's very important that you highlight that they are the gatekeepers. But I see a stark difference between community pharmacies in the African context and in the context of Europe or the US, in the sense that you can easily walk in, as you've mentioned, you can easily walk into a community pharmacy here in Kenya and walk out with half a dose of amoxil, even 5 capsules of amoxicillin. But going abroad, in the UK or anywhere else, you hear stories that you can barely get, even if it's a full dose, you can't just walk in and be given. You'll need a prescription. So where's the disconnect? Is it a policy issue, or is it just the implementation aspect of it? Is it that we are not implementing the policies that are already there, or people just do not want to follow that?
You're asking a very interesting question, and of course, being a pharmacist yourself, we know where we are headed. And it's not a policy issue. I think being in community pharmacy, you're there because you understand scheduling of medicine.
Yes.
It's simply an enforcement of regulations. And there are two ways here from the regulator's perspective, and I think the regulator has tried even to, to try and bring this out to the public. I remember, I think a year ago, there was an advisory that went out to the public and to health workers on the same issue on MR.
Yeah.
And I also look at it from the other point of self-regulation, because you know what needs to be done at the community pharmacy. So what is stopping you from doing the right thing? That's a question I would ask. So it's not a policy issue. I think it's clear in all our countries, even in Africa, the regulations are not the problem. They are there, they exist, they have been there in existence. But we allowed the rain to start hitting us at some point when we allowed the sale of antibiotics without a prescription.
Yeah.
So the big debate now is, how do we get off this over-the-counter access?
Yeah.
There are many health system issues that have to be fixed in terms of access to the nearest health facility. If I go in, I get the services, including the drugs and the diagnostics. So I look at it from two perspectives. One, you have the regulatory aspect where the regulator has to enforce what law says. And number two, can we try to self-regulate ourselves, understanding the challenge that is posed by our actions? Are we keen enough to self-regulate, or must we wait for the regulator to come and impose a fine on you so that you can follow what law says? I think it's just that place of keeping to what law says. One, and number two, also not waiting for the regulator to come and impose a fine on you. I think when we all begin to do the right thing, we will not lose our clients. I think if we give clients information, like I said, we are the authority. They will come back because they'll know you handled them the right way.
Yes.
What if they discovered that you exposed them to meropenem when they would have benefited from a very simple antibiotic? And when they need it 7 months down the line, it would help them, and they realize it was your fault.
Yeah.
What can that do? I think the damage is greater when we compromise on what law says. But when we adhere to what it says, we all stand to benefit. So it's two ways. From the person who's at the community level, self-regulate for the sake of tomorrow, and for the regulator to enforce what law says regarding the sale of prescription-only medicines, which I think is really, really important. Now, in the other countries, you will not get this in the West. I once tried. I couldn't. You have to see a GP, and maybe on your third or fourth appointment,
that's when you get there.
Yeah.
Interesting. So, in conclusion, because we need to wrap up, it is Wow Week.
Yeah.
What message do you then have for the healthcare workers in general, not just pharmacists, healthcare workers, and also in terms of the general public? Because we realize the patients are also key stakeholders in this. They're the ones who go and ask for that antibiotic. So what message would you have for them?
Yeah, so for the health workers, I think I go back to the place where I want to just emphasize that we are the authority when it comes to matters health. One of the key questions that has come back to us many times is what if the patient prefers this antibiotic? What if the patient has asked for the antibiotic? And I go back and ask the health worker, who's the authority? Who knows what's best for the patient? So the first thing I want to maybe just emphasize to the health workers is the place of education and advocacy. Take time to educate your patients. When they come to you, if you're the nurse, you're administering medicine, be consistent and administer according to the prescriptions that have been set. If you're the doctor who's prescribing, are we taking time to speak to our patients regarding their sickness or their illness and what you've prescribed for them and why it's important for them to adhere to the dose that you've given them? If you're the pharmacist, I think you also need to understand that a lot of information will come from you. You're the person who interacts with the patient at the end of that chain. When all has been said and done in that healthcare system, the last person who hands over this medicine to the patient is a pharmacist. Let's take time. When we have done rational use medicine surveys, sometimes patient encounters at pharmacy are like 1 minute, and patient encounters with the doctor are like 5 minutes. How much information can you pass on within a minute as a pharmacist? How much information can you pass on as a doctor within 5 minutes? Have you examined and accurately tried to diagnose what's happening? And if you're in the lab, quality tests and quality results back to the clinician so that they can be able to make the right diagnosis. I think that's where we want to start again. Everyone understanding their role and playing their part. And the other bit, apart from just handling the patients at the hospital level or the healthcare setting, is your role in the community. Be an advocate wherever you are. And I think that also helps to spread the word. Number 2, compliance to infection prevention and control guidelines. I think IPC is a cheap intervention. It can be done by everyone. And if every infection prevented is an antibiotic or an antimicrobial agent spared. If you're not able to control the transmission of infections, then it becomes very difficult. And one of the simple infection prevention and control interventions I would recommend and emphasize on is hand hygiene. Hand hygiene has been neglected in many of our healthcare settings, and we see adherence rates as low as 10% in healthcare settings. And yet we know from the studies done that up to 80% of all healthcare associated infections can actually be limited if hand hygiene is adhered to. So that if we comply to that, then we are able to reduce the transmission of multi-drug resistant organisms. And our HAIs actually are the ones that end up using a lot of the reserve antibiotics. They are very expensive to treat and very difficult to manage. And I say this because our 2023 report, the top 5 microorganisms isolated are all associated with healthcare-associated infections. Stubborn ones, Klebsiella pneumonia, Acinetobacter baumannii, Pseudomonas aeruginosa, E. coli, and Staph aureus. These are very difficult to manage, especially in the healthcare setting. So if we are able to implement our infection prevention and control interventions, I think that will be good. And my final aspect is just the place of rational use of antimicrobial agents. Sometimes we are the worst patients. We are the ones who actually drive AMR in our own settings. So let's be custodians for these drugs. And I think when we do that, then it will be better for everyone else in future. And of course, keep spreading the word. And if you're able to carry out operational research in your healthcare setting, use this data to inform decisions that are being made in your respective settings. Each of us has a role to play. For community health workers, we can spare time and break down information, give it to community health workers who reach the community more than we can. And I think that's also another channel of advocacy. For the public, I think one of the key messages that we are sending out to the public is, 1, do not self-medicate. Please seek the opinion of a healthcare provider. Go to hospital when you're not well. Let the doctor do the prescribing. Don't make Dr. Google your best friend. You will miss the mark. You will treat things that are not there. And when you do this, you're actually jeopardizing your future. And we are saying that when you will need this antibiotic, it will not be there for you because it will be so ineffective. So do not self-medicate. Avoid over-the-counter purchase of antibiotics. Please don't give pressure to your healthcare provider. What they have prescribed for you is the best option for you. So don't give pressure to them just because you have read and you think this is a superior drug. Your healthcare provider knows best and they're able to provide the best treatment options for you. The other thing I would want also to emphasize to the public, when you're in farming, you're keeping chicken, you're keeping cows, you're keeping goats. Prioritize hygiene in your farm. You will save a lot. Hygiene and vaccination. And it's not just for those that are in farming, either animal production or crop production. Even for human health, we are emphasizing on the role of vaccination in preventing infectious diseases from happening. So we are emphasizing on vaccination, and we are also emphasizing on hygiene and sanitation. Make sure that your surroundings are always clean to minimize the transmission of infections. Wash your hands frequently also to stop the transmission of infections from one person to another. And when we say wash your hands, we mean with soap and running water. Do it the right way, just the way we did it during COVID. But after COVID, I don't know what happened to the community. I don't know what happened to you. We forgot about washing hands. The healthcare providers also forgot about their sanitizer. So we're saying, let's go back to the basics. And I think the basics are cheaper. Prevention is definitely much better and cheaper than the curative part of it. So I think those are the key issues I just want to send out to the public as well as the healthcare providers. And let's not be resistant to change, because one of the key challenges or barriers to proper use has been attitude and resistance to change. Let's accept that we have a problem. And let's accept that we have been part of the problem, and we definitely hold the solutions. Thank you.
Thank you.
Yeah.
Now, that's a perfect place to end the chat.
Yeah.
And thank you so much, Dr. Wesangula, for making time to have this conversation with us. For me, at a personal level, it's very enlightening, and I'm hoping for the audience as well. They're going to gain some aspects in terms of antimicrobial resistance, prevention, and also in containing. So thank you, audience, for joining us today, and we'll see you on the next episode.
Thank you.